vascular and hemodynamic changes after renal denervation. This study is published in Clinical Journal of American Society of Nephrology in June 2013. The study was done in Germany. Coming to the background, renal denervation has been shown to be effective in reducing BP, blood pressure, in treatment-resistant hypertension. But the consequences on renal perfusion and renal vascular resistance, as well as central hemodynamics, are unknown. Coming to introduction, arterial hypertension is the most important risk factor for cardiovascular morbidity and mortality. Simplicity clinical trial program has suggested that catheter-based renal denervation is a safe approach to substantially reduce blood pressure in patients with resistant hypertension. Simplicity hypertension trial was a trans-catheter renal denervation trial. Simplicity Hypertension 1 trial is a series of pilot studies which they have initially followed the patient after renal denervation for 6 months, then they extended to follow the patients for 24 months, which did show that after renal denervation the decrease in blood pressure has remained on the low side. Simplicity Hypertension 2 trial is a randomized controlled study comparing patients with without renal denervation versus renal denervation procedure, which did show that the blood pressure decrease has sustained after a follow-up for at least a year. The Simplicity Hypertension 2 trial was done in New Zealand, Australia, and Europe. Currently, Simplicity Hypertension 3 trial is being enrolled in United States. Materials and methods. This is a investigator-initiated prospective observational analysis including 19 patients with treatment-resistant hypertension defined as blood pressure more than 140/90 mmHg despite use of at least 3 antihypertensives including a diuretic. Exclusion criteria is renal artery anatomy that is ineligible for treatment. Additional exclusion criteria were myocardial infarction, unstable angina pectoris, CVA within last 6 months, widespread atherosclerosis with documented intravascular thrombosis or unstable plaques, and any contraindications for MRI. Brachial office blood pressure and 24-hour ambulatory blood pressure monitoring. Brachial office blood pressure and heart rate were measured after 5 minutes of rest in a sitting position with an oscillometric device. The last 3 measurements were average. Ambulatory 24-hour blood pressure measurements were obtained with an automatic portable device. Catheter-based renal denervation was done by an endovascular technique in which femoral artery was accessed and the Simplicity catheter was advanced in each renal artery by angiography. At least 4 radiofrequency ablations controlled and regulated by a radiofrequency generator were applied within the lengths of each renal artery. Renal perfusion was measured with arterial spin labeling with an MRI in supine position using the flowing blood spins as natural contrast media. All MRI ASL images were analyzed by same radiologist. Renal vascular resistance was calculated as mean arterial pressure divided by renal perfusion measured by MRI ASL and therefore given in arbitrary units. Pulse wave analysis. Brachial blood pressure was recorded on the dominant arm with an oscillometric device and the last 3 measurements were averaged. Radial artery waveforms were sampled in the same arm by non-invasive technique, calibrated to measured average brachial blood pressure using sphygmocar system. Corresponding central aortic waveforms were then automatically synthesized from the radial artery waveform by a built-in validated transfer function. From the derived central waveforms, data are given for central systolic, diastolic, pulse pressure, augmentation pressures. Augmentation pressure is defined as the difference between the second and the first systolic peaks. Central augmentation index is defined for a central waveform as a ratio of augmentation pressures to pulse pressure. Central augmentation index is reported as normalized to heart rate of 75 beats per minute. Coming to biochemistry, routine methods were used for the determination of serum concentrations of cystatin C and creatinine. Estimated GFR was calculated using Cockcroft, Galt, and MDRD and CKD epidemiology collaboration formulas. Statistical analysis were performed using SPSS software version 19.0. Normal distribution of data was confirmed by Kolmogorov-Smirnov tests before further analysis. Normally distributed data were compared by paired t-tests and are expressed as median plus or minus standard deviation. Non-parametric data are presented as median and interquartile range. A two-sided p-value of 0.05 was considered to represent a statistically significant difference. Results: clinical and peripheral blood pressure data. 19 patients were included in this open label study. The clinical characteristics are given in the as average age is 62.3 plus or minus 19.2. Average age is 62.3 plus or minus 9.2. 14 men and 5 women were involved in the study. Average body mass index is 30.4 plus or minus 4.1. Total number of antihypertension agents used are 5.6 plus or minus 1.3. 7 of the subjects were on ACE inhibitors, 14 of them were on herbs. Calcium channel inhibitors were used on 17 subjects, vasodilators on 9 subjects. 32% has coronary artery disease, 63% has diabetes mellitus, hypercholesterolemia, dyslipidemia in 37% of the subjects. Coming to the blood pressures, peripheral of systolic blood pressure measured before the procedure, one day before the procedure, 3 months after the procedure, and 6 months, has reduced, and which is also clinically significant, statistically significant. Mean arterial blood pressure, diastolic blood pressure, heart rate, these are all office measures, were also decreased and they were statistically significant, except for the office heart rate, which hasn't changed much. Central systolic, diastolic pulse pressure, augmentation pressure were also decreased compared to one day before the procedure and 6 months after the procedure, and which is statistically significant. 24-hour ambulatory blood pressure was also decreased compared to one day before the procedure and again 6 months after the procedure, and is statistically significant, except for the mean diastolic blood pressure, which was not statistically significant. That's the 24-hour ambulatory mean diastolic blood pressure. Coming to renal hemodynamics and function, renal perfusion was not statistically significant different between day -1 and +1 after renal denervation procedure. The renal perfusion pressure was also not significant change between day -1 and 3 months. Renal vascular resistance was significantly reduced from 432.1 versus 390.6 3 months after RDN. Renal function, irrespective of whether assessed by cystatin C or serum creatinine, was not statistically significant different at any point period. Accordingly, there was no significant difference in estimated GFR measured using Cockcroft, Galt, MDRD, CKD, PI formulas at any point. No patients developed significant doubling of serum creatinine or even a 25% or more reduction of eGFR after RDN at any point. Serum creatinine measured 1 day before the procedure, 1 day after the procedure, after 3 months, hasn't changed much, and it is not statistically significant. Likewise, cystatin C and GFR also hasn't changed much, and which is also not statistically significant. Central systolic and diastolic blood pressure is significantly reduced 6 months after RDN. Central pulse pressure and augmentation pressure reflecting arterial stiffness of large arteries were significantly reduced 6 months after RDN and in parallel compared with day before. Augmentation index decreases 6 months after RDN. Coming to the discussion, first study to measure renal perfusion using MRI arterial spin labeling before, immediately, and again 3 months after RDN. Major findings is that despite reduced systemic blood pressure, renal blood flow did not change after RDN, either immediately or 3 months after RDN. Second major finding is that RDN, that's a renal denervation, significantly reduces central blood pressure, central pulse pressure, central augmentation pressure, and central augmentation index. Conclusion is that renal denervation procedure using simplicity catheter reduces central blood pressure, which may improve cardiovascular prognosis. Despite reduced renal vascular resistance of the kidney, renal perfusion function did not change immediately or 3 months after RDN.